Conn syndrome. So this is a disorder of adrenal cortex where there is hypersecretion of aldosterone. So it is a case of primary hyperaldosteronism. Now, primary hyperaldosteronism has basically two varieties. One when it presents with a normal potassium level, and the other when it presents with low potassium levels. So, in case of normal potassium level, around 70% is associated with hyperplasia and rest are present with unilateral adenoma. In case of low potassium level, most are because of unilateral adrenocortical adenoma, and around 20 to 40% are because of bilateral micronodular hyperplasia. So, following this, the next important step in any primary hyperaldosteronism is to know the clinical features. So, such patients are usually female patients in age group 30 to 50 years, presenting with hypertension, or they may present with other non-specific features like headache, polyuria, polydipsia, muscle weakness, and cramps. So then we proceed to the biochemical investigation, which includes plasma aldosterone and renin activity ratio. So if the ratio is more than 30, then we proceed to the further confirmatory biochemical investigation, which is 24-hour urine aldosterone level and plasma aldosterone level. The 24-hour urine aldosterone level is done by IV saline loading test, in which basically around 200 milliequivalent of sodium is given, which basically equals to 5000 milligram of sodium daily for 3 days, followed by measurement of urine aldosterone level, and in case of this is done by oral loading test, where 2 to 3 liter of isotonic saline is given over a duration of 4 to 5 hours, and then plasma aldosterone level is checked. The basic idea over here is to create a hypovolemic sodium excess state. So if aldosterone levels are not suppressed, we know that it is a case of probable primary hyperaldosteronism. So I again repeat from the beginning. Once we know that we have a patient of a primary hyperaldosteronism with the clinical scenario, say a female of around 45 years of age present with hypertension, and we suspect that this patient might be having primary hyperaldosteronism, we would be doing our first test, which would be the plasma aldosterone and renin activity. Now, if this ratio is more than 30, then I would be doing my IV saline and oral saline loading test. So in case of IV saline loading test, we basically give 200 milliequivalent of sodium, which is equal to 5000 milligrams sodium daily for 3 days, followed by measurement of urine aldosterone level. And in case of measuring the plasma aldosterone level, we give oral loading test where 2 to 3 liter of isotonic saline is given over a duration of 4 to 5 hours, and then plasma aldosterone level is checked. The basic idea over here is to create a hypovolemic sodium excess state and to check if the aldosterone levels are suppressed or not. So if it is not suppressed, then it is a case of a probable hyperaldosteronism, where we next move to the localization, for which we do thin cut adrenal CT. Normally the slices are taken at 3 mm interval. So on this, if we find that it is non-lateralizing, that is, I'm not able to make a diagnosis, and your age is more than 40 years, then we do adrenal vein sampling. Now, on the other hand, if the adrenal mass is noted usually more than 1 centimeter, there is a normal contralateral adrenal gland, and age is less than 40 years, we go for the surgery, and surgery over here is adrenalectomy. Now, in case of adrenal vein sampling, here blood from vena cava and both adrenal vein, not one. The keyword over here is both adrenal vein and aldosterone to cortisol ratio is determined. So in case of adrenal vein sampling, blood is taken from both the adrenal veins and the inferior vena cava, and the ratio of adrenal to cortisol is determined. The unbalanced ratio of aldosterone cortisol in left and right adrenal vein with ratio to one side. So over here the ratio of aldosterone to cortisol in either left or right adrenal vein with ratio to one side is measured, and if it is fourfold increased, repeat, if it is fourfold increase, then the other gland. So I repeat this part here. The unbalanced ratio of aldosterone and cortisol is determined in the left and the right adrenal vein with ratio one side being measured and it is fourfold high compared to the other gland, then it is said to be lateralized. So if it is lateralized, then we again go for adrenalectomy. If it is non-lateralizing, that we do not get it to be around a fourfold increase, then it is probably due to bilateral adrenal hyperplasia, where we can go for a medical treatment. And this medical treatment, we have a drug commonly used, spironolactone. So coming back to the flowchart again for the revision purpose, the basic idea is to follow the adrenal into flowchart, which would give you an impression what to do next, which would help you to answer the next best step or the best step in your exam. So, an adrenal cortex, it is a disorder of adrenal cortex, is a disorder leading to hypersecretion of aldosterone, where there is normal potassium levels and low potassium level. In case of normal potassium level, it is 70% associated with hyperplasia, whereas the low potassium level, it is unilateral associated with adenoma. Now, in case of low potassium level, I would like to add one more point over here. It is often related to KCJN5 mutation, which is encoding potassium channels. Such patients would be usually a female patient in an age group around 30 to 50 years presenting hypertension, where we would go for a biochemical test, that is the plasma aldosterone renin ratio. Aldosterone renin activity, a ratio of which more than 30 would prompt the further confirmatory biochemical test, which would be the 24-hour urine aldosterone level and the plasma aldosterone level. Now in this case, if it is ratio less than 30, we basically go for alternate diagnosis, right? Now in case of the ratio being more than 30, we go for the next confirmatory test, where it would be IV saline loading test or the oral loading test, which has been explained. The confirmatory test would give us an idea it to be a primary hyperaldosteronism, following which we would be doing the localization part, followed by a thin cut adrenal CT, which is usually taken as slices of 3 mm. Now, if in the CT scan we find that the mass is around 1 centimeter, a normal contralateral adrenal gland, and age less than 40 years, we go for surgery. If not, then we go for the next step, which is the adrenal vein sampling. Over here, from vena cava and both adrenal veins, aldosterone to cortisol ratio is determined. So we need to see whether the one is increased around fourfold increased. If it is lateralized, then again surgery. If non lateralizing, then we go for medical treatment in form of spironolactone.